Very good morning, good afternoon, and good evening to everyone who has joined today's webinar. My name is Shrija and I will be host for today. Very warm welcome. This is the fifth webinar in our Recurve Academy learning series, and all the previous one can be seen here. I'm putting a link on the chat box, and you can explore the one that we have already done. We have also added the recordings and the upcoming one. Please go ahead and register for all the interested webinars that are there in the series. So in this series, what we'll do is we'll explore how public systems can be powered and digitally transformed so that we create a thriving ecosystem, which is rooted in collaboration, and it is also powered by some, fantastic technology that we talk about nowadays. It's DPI, while keeping focus core to the citizens, that is citizen centricity. And what we'll do today is we will unlock the potential of health DPI in our journey as eGov to see digital transformation of health campaign management. So for sharing the insights and experience for implementation and impact done by eGov in the health space, we have Ranjani Rajagopal with us today. She is the Associate Director looking after the health mission. She brings over a decade of experience in digital and public health, focusing on program management, go-to-market strategy, and digital service delivery. Her expertise lies in bridging the gap between tech and public health initiatives. So what I'll do is I won't take much of time, and I will hand it over to Ranjani to take it over. So very warm welcome, Ranjani, to you for this webinar, and all yours.
Thank you so much, Rija, for that introduction. Good afternoon, good evening to everyone. Welcome to today's webinar. Like Shrija said, we are going to be talking about the running national health campaigns using Digit HCM, but the focus is going to be on how a product like Digit HCM, if a country is using it, how should they look or go about digitizing their campaigns rather than the product itself. We have a separate webinar that's coming up later on to cover that particular topic. So with that said, I'm going to quickly share my screen, and then we can start off with the session for today. Yeah, this I think is already spoken. So before we get into the details of the health campaigns and how we go about running it, just a quick recap of what eGov is and what we do. So eGov is a not-for-profit organization that's about 23 years old. We work in catalyzing in the transformation of public service delivery, and we work very closely with the government and the market players to do that. Right. And what exactly do we follow? We follow a multidisciplinary approach. We provide an open source platform called Digit, which enables that, along with building local capacity and also activating partner networks. By doing all of that over the years, we've been able to contribute in a number of sectors, including local governance, public health, water and sanitation, and public finance management, to name a few. And what we see on the right side is essentially the impact that we've been able to create with all the work that we've been doing across these sectors. I would like to take your attention into that. We have presence in about 9 countries with over 200 plus partners that we've been working with. A quick summary of our journey so far, right? Just to recap for people who have heard about us before. So we started our journey 23 years ago by deploying point solutions, right? And then for us, we understood that for us to scale and create an effective ecosystem scale effectively and move across, create an effective impact in the ecosystem, we pivoted and started building the shared digital infrastructure, which could now be driven by the ecosystem, enable the ecosystems as well. And that has enabled us over the last couple of years to extend to new sectors and to new geographies. So from deploying those point solutions, we have now moved into a platform approach, or the DPI approach, which has enabled a lot of extension and expansions into newer sectors and geographies. That said, I will now move specifically into the health sector. eGov has been in the health space for about 5 years now. There are broadly 3 main offerings that we have, right? We started off our journey in the health sector with the DIVOC platform, which provides an untamperable verified credentialing platform, right? So basically, the vaccine certificates that were generated at the end of the COVID-19 vaccines, which most of us received, or all of us received, were generated on this platform. This was successfully deployed across 5 countries in the world, and over 2 billion vaccine certificates were generated in that process, right? And after that, the next major offering that we have as a part of our health mission is that of Digit HCM, or Digit Health Campaigns Management. This is essentially a tool, end-to-end campaign management tool, that helps in driving efficiency and effectiveness of the campaigns. And as we speak, we are live in about 7 countries across the globe, and about 40 million lives have been touched with this particular platform that we have. The third offering that we have is the Care Platform, which is a healthcare management kind of a platform, which provides a range of healthcare services from hospital management to palliative care and even critical care. And our presence with respect to the Care Platform has been limited to India. We have been deployed it across multiple states in the country. So as discussed earlier, today's focus is going to be about Digit HCM and how countries can go about deploying it. Just to give a context for some of you on the call, in a number of low and middle income countries, routine health systems are not very well developed or well defined, right? What by routine systems, I mean primary healthcare facilities or secondary healthcare facilities. Those are not well defined. And in places where that happens, a lot of critical life-saving interventions are delivered in the form of campaigns. And what exactly is a health campaign? It happens over a short period of time, about 5 days, where a particular medical intervention is distributed to the population to protect them from a particular disease, right? For example, just before the monsoon season, some of these countries distribute a bed net to the population to kind of protect them from a possible malaria, right? So that's exactly malaria outbreak. So that exactly is how health campaigns happen across the globe. And HCM is a tool that has been built to improve the effectiveness of that campaign. So across, if you look at the health campaigns, there are a number of challenges that countries face in terms of number of challenges that countries face while executing a campaign, because these are all national level campaigns. At the central level, the Ministry of Health does not have a view of how the campaigns progress. They do not know if all of the beneficiaries have been reached, or is there sufficient stock that is available? Is there a potential stock out that might happen? Or they do not have sufficient data to even plan for that campaign. From a health supervisor perspective who is on the ground, they are constantly firefighting, right? They do not know if the teams that they are managing have actually been able to deliver on the targets that has been provided. Is everything going on track? They do not have a view of that because the information does not flow back to them. And you should imagine that in a lot of these cases, the health supervisors are in one location and frontline workers are deep within remote locations to doing or delivering the healthcare services as necessary. From a frontline worker perspective, the major challenge is there's a lot of runtime issues that they face while delivering those interventions. The tasks are repetitive, and sometimes they are not even paid on time at the end of the campaign. So all of these complexities, right, like low, and all of this resulted in low campaign effectiveness. The coverages were not met, or the campaigns did not really conclude. Countries deemed it as complete, but it did not happen. There was limited visibility, and there was limited ownership for the Ministry of Health, and all of this led to countries, starting to rapidly digitalize their campaigns. They started deploying digital tools, putting a lot of efforts in digitalization, but those efforts were suboptimal. And why do I say suboptimal? Is because it was duplicative in nature. What do I mean? Is that within the Ministry of Health, there was a polio program, there was a malaria program, and there was a neglected tropical disease program, and each one of them followed a different approach for digitalizing, or they independently digitalized their programs, right? So that was a duplicative. It was very duplicative in nature because it was the same set of activities that were to be now done by each of the programs. Furthermore, with each of these programs digitizing their campaigns independently, there was data that was locked in silos and was not available for other programs to use. There was absolutely no interoperability. So sometimes the data that's captured by one system can be taken and built on top of that, right? So that never used to happen because the systems were not talking to each other. And when we have multiple systems that are getting deployed, it is very difficult and also costly to kind of scale it and sustain it in the long run. And in most of these cases, a lot of these digital tools were not owned by the country themselves. The tools and the data were not owned by the country. It is all of these challenges which kind of resulted in a need for people to look at digitization of campaigns very differently, right? It was, or a new approach was kind of needed. And that is where we kind of proposed the movement from a traditional approach to a platform approach. As you can see, as I was just describing earlier, in the traditional approach, for each of the programs, there is an independent digitalization component that happens, with each one of them having its own infrastructure, with each one of them having its own application. But at the end of the day, the users and the beneficiaries are the same set of people. So this was making it a very difficult experience for the people who are interacting with these systems. The integrations between these systems became difficult. Furthermore, there was data that was getting fragmented across these multiple systems. Now, in the platform approach, which is exactly how Digit HCM has been built, there is a common platform, in this case, Digit, which has shared registries and common services, right? So these services can be used across these multiple programs. Similarly, by shared registries, we mean beneficiary registries or registries of frontline workers. All of this is now made available across all programs and is present at the platform layer. And on top of the platform layer, we have the product, which is the health campaign management tool in this particular case, which is then configured to cater to the different types of programs, be it polio program, malaria program, or the measles program. So for all the users who are interacting with the system, they are essentially looking at one app which is catering to all of their program needs. So that makes it a better experience. And furthermore, with a platform like Digit, there are open APIs that are available, which ensures easy interoperability with other systems that are already present in the public health ecosystem. So as just to summarize, the three key pillars of a platform approach is the reusable modular building blocks, which is what we're talking about as common services, which can get packaged and used for the different use cases. Then there is the shared registry, which is a single source of truth for all campaigns and not created separately for each one of them. And there is open APIs, which enables interoperability. With this, I'm going to play a short 5-minute video which kind of summarizes or talks about what we've been saying so far about HCM. Let me play it. Shrija, let me know if the audio is coming through.
Audio is not, it's not audible.
Oh, okay. Okay, just give me 1 second. I will reshare this. I have it. Sorry. Sorry.
Health campaigns are critical for delivering life-saving interventions across the world, especially in Africa, where routine health systems are still maturing. Health campaigns prevent millions of deaths and reduce trillions of dollars worth of disease burden. It takes months of planning, thousands of people, and billions of dollars to run campaigns. While digital tools are bringing about some efficiency, they are not doing enough. Coverage still remains uncertain, and cost effectiveness a major concern. Current solutions don't seem to support the entire campaign cycle. Operations are fragmented from setting up to delivery. Coordinating is hard, stockouts are frequent, and payments get delayed. Different campaigns use different solutions which often don't work together. And efforts like enumeration have to be repeated every year and in each campaign. This leaves the team stitching information across multiple silos, since real-time data is never available. As it stands, Decision makers face an impossible choice. Digital tools are either free but not fit for purpose, or they do the job but cost a fortune, taking money away from inventory, wages, and actual delivery. These realities made it very clear that point solutions cannot do the job. Health campaigns needed a holistic digital transformation. This is how Digit HCM came into being. HCM stands for Health Campaign Management, a free, fit-for-purpose open source product built as a digital public infrastructure to help countries transform health campaigns. Right from setting up campaigns to planning inventory and tracking delivery, it has all crucial components to simplify end-to-end operations and make decisions in real time. For national teams, it provides a digital headquarter to quickly set up and configure multiple campaigns, track progress with real-time data, and a centralized help desk to ensure that campaigns run without bottlenecks. Managers and supervisors get a co-pilot to run end-to-end operations. They can quickly track registrations and delivery, manage attendance and stocks, resolve complaints, make payments, and monitor progress, all from a single app. Frontline workers too have a digital partner, a mobile-first app that readily works offline, simplifies routine tasks with built-in data checks, easy navigation, and on-call support. It also ensures they get timely wages with smart payments. You see, when things are designed holistically, the entire system just works. And that's what Digit HCM does. It is not just another solution. It is built to be a strategic digital infra for public health, to enable high-speed transformations and new possibilities. Modular building blocks allow the same product to be reconfigured for different campaigns and diseases. And these building blocks can be reused to create new solutions in routine health, primary healthcare, and so on. Shared data registries provide a single source of truth from day one. All data of campaign staff, health facilities, and households can now be created once and leveraged across campaigns today and for routine healthcare tomorrow. Open APIs make it interoperable by default. No more worrying about siloed data or fragmentation. Digit HCM can work with any new or old system. As a true digital public infrastructure, it makes digital sovereignty possible, such that all data and digital product assets can reside within the country. And national agencies can decide the roadmap of health digitalization. Yes, that's why HCM is a game changer. It is open source. It is free. It is yours.
Right. So I think, as mentioned in the video and what we've been talking about, we've looked at the advantages of the platform approach, how Digit HCM is different from what the other tools offer. So now I would like to talk about what does it mean for a country, right? Now, how can a country plan for digitalization differently when using a tool like HCM? So I think with a tool like Digit HCM, countries should start looking at campaign digitalization as a horizontal and not as a vertical. But what do I mean by that is that digitalization should be a shared thing across all of the programs, irrespective of it being malaria, polio, or NTDs. It should be planned in a way that it is planned for all of these programs put together, not independently for each of those programs. And when countries do it that way, what happens is that there is a shared infrastructure or a single infrastructure that now becomes available across all of these programs. There is an application, a single application, which can now be accessed again by all of these programs. And there are registries, which is common and reused and enhanced continuously across these programs. In the subsequent slides, I'm going to take each one of these and talk about how this is advantageous to a country, right? And also talk about with some examples of how it has happened in real use cases as well. So when you look at a shared infrastructure, right, especially with an infrastructure like Digit, which has been built for scale, when it is used for running multiple campaigns at a national level in a country, there is economies of scale that kicks in, right? What we have noticed is, and this what we've noticed is that when running multiple campaigns across the nation, the infrastructure cost per beneficiary or per user reduces by almost 90% when we go from a small, covering a small district to an entire nation, right? So that's something that we have seen. Similarly, in the earlier case, in the earlier kind of digitalization, where every program was using its own instance of the application to run their programs, there are multiple instances that are getting created, which not only makes it difficult to manage but also increases cost. Now, with a single instance which can now run multiple campaigns of different programs on this, it becomes easier to manage, and the cost of the infrastructure also reduces. We've in fact seen that when running about 3 campaigns on the same infrastructure, the cost reduces by almost 60% when compared to running an individual campaign in one infrastructure. And with one single infrastructure now available, it is easier for countries to extend the application or to newer use cases as well, right? So, for example, in some countries, we started off by providing or supporting the BedNet campaign, which was about distributing bed nets to the population to protect them from malaria incidences. But then using the same infrastructure, extending it to a drug distribution campaign where drugs are given to children below 5 years to protect them again from malaria, it was easier and it was faster. It took us only about 50% of the time it would take for, I'm talking about the first time deployments. It reduced by almost 50%. And that's when extending to a newer use case like indoor residual spraying, it further reduced by almost another 50%. So there is advantage that comes with using a single platform across all programs and at scale from a cost perspective and from efficiency perspective. Now, when we look at it from a single application that's getting used across multiple campaigns, what it enables is that it enables the countries to respond faster to emergencies, and it also brings in cost efficiencies, right? Now, to talk about specific examples, in one of the countries that we operate in, there was a cyclone which had hit that country, and there was a threat of a potential malaria outbreak in that country, which meant that, and the country had quickly decided to go ahead and do a emergency BedNet campaign to support or to protect that particular area from malaria. Since the application was already ready, the infrastructure was already set up, it enabled them to respond faster to those emergencies, right? Within a short span of, while they were making this decision, the technology layer became available. There was no need, because it was the same application now getting used across multiple campaigns, the at the higher levels, the provincial levels or the state levels and the national level users were pretty much the same people who were already adept with the solution. So it made, there was no need for people to get trained again, and that meant faster response times to the emergency situation. So in this particular case, the country went live within a short span of about 7 days, and the campaign happened to protect the affected population from malaria. And that the second point that has been mentioned here is also kind of linked to that, because now with the same application now being used across multiple campaigns and across the same campaigns in multiple years, the users become comfortable with what is being offered. There is no need for them to be retrained on how to use it or how to manage it. So that at the end of the day, the training cost per frontline worker reduces, and we've seen that it reduces by almost 40% as we move from one of these from one campaign to another. And most of these analysis is for just a 2-year period, right? I'm pretty sure that as we move forward, a lot of these efficiencies will also kick in. And again, it's not just the people who use the application. There's also a component of solving issues that might occur during the campaign. And that is typically done by a central team which is present within the Ministry of Health in the countries. So when when they are using the same application, same technology, they also become very comfortable and they learn a lot more about that application, making it easier for them to manage the technology in the long run. So a local capacity also gets built, making them confident about managing things by themselves. And this is something that we are seeing play out in a number of countries that we operate in, where the countries have been able to manage a lot of the implementation or the implementation aspects of it by themselves. Uh, the third part is again with the shared registry. What happens is that the data is created once and it is reused and enriched continuously. What do we mean by that? Maybe Digit HCM is instantiated in the country for the first time in one of their campaigns, right? And they would go about registering the beneficiaries. Now a beneficiary registry gets created. When the subsequent campaigns happen, which could be polio or any other campaign, they could reuse the same beneficiaries, because at the end of the day, the health frontline workers would go to the same household, and maybe the beneficiaries will be just the children below 5 years of age, but at least the household record has been created, which can then get enhanced to add details of children below 5 years. And then that's how, registry is created once and it keeps improving as we move from one campaign to another. The advantages of having something like this is that there is no need for frontline workers now to re-register people every time they go out on the field. That also takes about 2 to 3 minutes of their time, right? And now, if the beneficiary registry is already existent, they don't have to recreate it. They can just use that and add details of what has been delivered this time around. And this helps in saving some time for the frontline workers, who can now focus on social and behavioral change communication, right? Because that is what is going to drive better adoption. And at the end of the day, it is not just about delivering the intervention, it is also ensuring that the intended audience use it well so that they are protected, right? So this reuse of registries help in reducing that time, which will enable them to concentrate more on some of these communication. It will also help in effective cohort tracking, right? What do we mean by that? Now there is a beneficiary view that countries can look at, right? The decision makers can look at it. For example, in the case, I'll talk about two types of examples here. If you take a campaign like seasonal malaria chemo prevention, where drugs are provided every month to a child to protect them from malaria, even if one of those doses is missed, then the risk of the child getting malaria increases drastically. So it is very important for that child to get all the doses during the peak malaria season to ensure that they are sufficiently protected, right? So now with the beneficiary registry getting created and used across those cycles, it becomes easier for the campaign program managers to look at it and understand how many of the children who have received the first dose have received the subsequent doses as well, or where have there been misses. So that can give them an idea that this child is potentially at a risk because they have not received, and they can take corrective measures accordingly. Similarly, this is just within a campaign, but even across campaigns, right? If countries want to look at from a beneficiary perspective, okay, this household has received a bednet, the children have received an SMC, and eventually, when you interoperate through the APIs with case management systems, and you realize that the household still had malaria cases reported, then it would clearly indicate to the to the authorities that somewhere maybe the communication was not good, or something else has to be changed, right? So that will help them understand where things are going wrong and can also take corrective measures accordingly. The other advantage is, as we have seen, we were talking about duplicative approach, right? So every campaign has a lot of micro planning that happens. And before every campaign, it's a huge process where they take data that's available, could be census data, and then use that to extrapolate the current population and plan for the campaign. But now what happens is that they can do the entire planning exercise based on a very recently concluded campaign. They do not have to depend on a census that was conducted many years ago, but rather on a campaign that happened a couple of months ago. They could take that data, reuse that to kind of share, to kind of improve your micro planning and and make it easier as well. The process becomes effective that way. So these are some of the advantages of the three things that when countries start looking at it as a horizontal, these are some of the advantages that they would see, especially when using a tool like Digit HCM. And in general, with Digit HCM being an open source platform with its modular building blocks and open APIs, what it enables is that since it's open source platform, it is country owned. It is not owned by anyone else. It's the data is the country's, right? And countries can eventually look at leveraging Digit to kind of do innovations on top of it to cater to newer public health use cases. For example, the countries want to build a case management system, they could use the same platform, reuse some of those modular building blocks, and build something new to cater to that particular need. And there is, with HCM, one of the feedback that we keep getting from a lot of our countries is improved data observability, which kind of helps them in decision making, faster decision making. And of course, it being an open source platform, there is no vendor lock-in. We are, as we mentioned in our initial slide, we are about enabling the local ecosystem, and there is no one single person who would be, there will be multiple partners who would be enabled on this, giving optionality to the country itself. With that, I will just quickly give some statistics around our journey so far from a HCM perspective. We began our journey in Africa with HCM in August 2023. And as we speak, we are present in about 7 countries. As mentioned, 40 million population covered. The countries have been highlighted on the slide here: Senegal, Liberia, Nigeria, Mozambique, Burundi, Togo, and Congo-Brazzaville. And a number of different types of campaigns. Some of them are malaria, some of them are NTDs, and we're also getting into polio and measles. I think that's about it from my end. I can stop here for questions.
Thank you, Ranjani. Just before we open up with the audience for questions, if you want to consolidate into like 3 key takeaways for everyone, what will that be?
Yeah,
Because you mentioned a lot of advantages. So, like highlighting just 3 that you think.
yes, I think the first and foremost thing, I think the key takeaway is digitalization of health campaigns is no longer a vertical subject. It is a horizontal subject, right? So people need to start planning for it from across all campaigns rather than an individual campaign, right? And the reuse of registries, that becomes absolute. The second point that I want to highlight is the reuse of registries, right? A lot of analytics, which will in turn feed into your policy frameworks that the countries might want to implement, will be dependent on how well those registries are reused across multiple campaigns, because that is when a lot of analytics can happen and people can understand. I had quoted a couple of examples, but more than that can also happen for countries to make decisions. So I think that's the second most important thing. And the third is it is built for scale, right? The countries should look at using the platform at scale for a national rollout, and rather than doing smaller pilots, because that's not when the efficiencies would kick in. It's only when you do it at a larger scale things really happen. So I would probably summarize those 3 as the key takeaways.
Yeah. And what are the different use cases where we have already used same platform? Can you just share a few?
Yes. So I think with the same platform, we have been able to support PetNet campaigns. We've been able to support seasonal malaria chemo prevention, which like I mentioned, below 5 children to protect them from malaria. We've been able to use it for indoor residual spraying, which is the spraying kind of a campaign. NTDs, neglected tropical diseases like lymphatic filariasis, schistosomiasis, all of that has been supported using our platform, the same platform. And we are now extending to polio and measles as well. So it is this single platform and 0-dose vaccination. So it is this single platform that's getting used across these multiple use cases. And it can be extended to others as well. And now as I speak, I remember that we've also supported an azithromycin campaign or vitamin A campaign, which is nutrition and reduction of under 5 mortality rates. So we've been able to support a diverse range of campaigns.
So basically the possibilities are endless. So if
Yes.
people can imagine, this can be done.
Yes, yes. Because at the end of the day, there's a lot of similarities in terms of workflows across all of these campaigns. So it is not the what varies is really what is being delivered as an intervention to the and the beneficiaries to whom it is getting delivered, which can get easily configured. And so any type of campaign, from routine campaigns to seasonal campaigns, all of that can be taken care of.
Thank you, Ranjani. So now I'm opening it up for all the audience. Please put your questions on Q&A or chat box, or even if you can raise hand, we can start with that. I think Shreyas has, yeah, Shreyas, please go ahead. Shreyas, do you have any question? Okay.
Hello.
Yeah.
Yeah, hi. Hi, Ranjani. Thanks for the very interesting presentation. I just had a doubt. Is there a comparable system that India currently uses for its different health campaigns, or do states have their own sort of ways of provisioning for these systems?
From our understanding in India, especially, there are not any systems that are available to run health campaigns. Most of them are paper-based, is our understanding. Again, in India, it also does not happen at the national scale that we are talking about in Africa. It happens in small pockets. And right now, from our understanding, it is not digitized.
So next is from Bhavna. Bhavna, if you can ask your question. Okay, you have already shared. Yeah, please go ahead.
So wrote it down. Thank you. I think very fascinating. Thank you for this. When you say campaign, you is it primarily communication, monitoring, and tracking, or can there be? Is there a provision for a two-way, as in the beneficiaries can track their input or feedback as well?
Okay. At this point in time, it is not a two-way thing, right? It is for, and it's not a communication campaign essentially, right? It is about delivering actually medical interventions, which could be a drug, which could be a bed net, which could be anything, or a vaccine for that matter. So right now, it is about how the health workers can deliver and record that they have delivered to a particular beneficiary. We do not have a beneficiary layer that has been built yet, but that could be possible. In the places where we operate, the smartphone penetration is not is very very low, and even internet penetration is very very low. So that's one of the reasons that we consciously did not have anything built from a beneficiary perspective.
So basically, this is like a service delivered that they require from the government, and service being delivered using this platform, so that both of them have visibility of what is, what is their accessibility and how government can reach out to them. Any other questions that we have?
I think I see a question from Anand. Can you share any specific examples wherein the effectiveness of such campaigns was measured? So I think I can give you some examples of how it has helped improve campaign effectiveness, right? So uh, it will get into a little bit of operational details. So the way HCM has been built is at the time of when a healthcare worker goes to a beneficiary that delivers an intervention, it captures the details of the beneficiary. That's one thing, but it also captures the geo coordinates of that beneficiary, right? Now, all of that data from that frontline worker gets fed back into the dashboard, which is now viewed at the central level by the decision-making authorities, right? So when they look at it, and this is a specific example that's happened in one of our countries where there are daily review meetings happening, right? So they look at the map, which is a geospatial map showing the distribution of the population, and on top of it is overlaid the distribution of where the interventions have been provided. So they've been able to very clearly say that, okay, this entire region has been missed out by our beneficiaries, or sorry, by our frontline workers, and they were able to effectively do that. And in one of the states where we operate in Nigeria, the coverage increased to almost 94% from where it was, and it was one of the highest coverage in the whole of the country, right? So that was feasible because of the data that was getting captured.
There is one more question. So this is more powerful for product info distribution is Bhavna's questions, and how can one get a demo of how to use the platform?
So this is more info for, yes, product distribution, any kind of intervention distribution is what is how it's been built at this point in time. Yeah. And how can one get a demo of how to use it? Yes, you can reach out to us, and we do have some videos which can be shared with you as well. The other option is also to we can have in-person demos, I mean online demos that can be done.
Any other questions that we have from the audience? What I'll do is I'll just put out an email ID which you can write to us, and we will connect you to the relevant team, so that if you want a demo, if you want to understand our products better, because Digit is it's urban governance package. It's it's a DPI which has multiple products, and one of the product is HCM, which Ranjani talked about today. So if you want to know more, please write to us. We'll be more than happy to take it up.
There's one more question, I think. How do you link? What do you do with geospatial data or landscape? So, like I mentioned, the geo coordinates of the beneficiaries are captured, right? And what we do is we use open source maps. So on the maps, you can see the physical structure of the houses and all of that in that particular area. And on top of it, that you can see the dots of where the distribution has happened. So that there are two ways in which it's helped countries, right? One is you are able to now see if there is a household structure in that open space map, open street map, where there are no dots, that household has been missed or that area has been missed. And the other is if there are too many dots within a very short span, then probably there has been some miss around. Are people delivering things standing in a single location instead of going door to door, or any of the SOPs are not getting followed, then that can get highlighted. I hope that answers your question, Farooq.
Farooq, do you have any follow-up questions? Shreyas, please. Okay, thanks. Yeah, please go ahead, Shreyas.
Hello.
Yes.
Yeah, hi. So yeah, I just had one more question. So this tool across different campaigns has the scope for becoming like a medical records repository of sorts for individuals also, right? Like across campaigns, if you look at it, so each record then speaks to an individual, and you have some sort of sense of the medical history of the person. And so does this sort of induce any data protection challenges across different countries or different regions? Number one. And also number two, from a research and sort of preventive medical academics point of view, is there, has there been any interest or thoughts on use cases? Just the
Okay. From the data protection perspective, I think Digit as a platform has a lot of those security and protection aspects already built in. And in a lot of these countries where this is getting used, right, there are also country-owned or country-owned devices on which it is installed, right? And all of ensuring that the data is synced and no data is taken away by people, it is monitored using like mobile device management software, which enables the country to control it from a central location and ensure that data is protected. But as we speak, a lot of countries are also moving from country-owned devices to bring your own devices because of device shortages that might occur, especially when you're running multiple campaigns parallelly. So what we have done is we are building, actually, as we are building it in the application itself, such that the data gets erased at the end of the campaign once it is all synced, and people are not able to access it outside of the campaign period, and data is encrypted and placed in the phone so that people are not able to take it use it, right? So those are some of the measures that we are also trying to put in place right now, as countries are switching and moving away from an MDM or country-owned device to a bring your own device. And I think on the research part of it, on how to use the data, I think we've not done a lot of thinking around that. At this point in time, yes, there is a lot of data that is available. We are looking at how it can help countries in making decisions to make the campaign campaign effective. But beyond that is something that we will have to start thinking about.
Any other questions that we have from the audience? So there is one question. I'll just read it out so that everyone can hear. It says, you mentioned that it is an open source platform and it is structured in a way that you can tweak the code to fit any campaign. Let's say you want to conduct a census in preparation for other campaigns. How does one go about that? Is the tweaking done solely by your team or is it done in collaboration? And also, do you have to be a developer to achieve that?
Yes. Thanks, Faiza, for the question. Right now, if countries want to do just a census before the actual campaign that can be done using HCM, the registration module that we
Ranjani,
have
your
can be
voice is
used
breaking.
separate. Like module building blocks, they do not have to. They are that if you have to take one module, all of it has to go together. So the registration module alone can be used. Oh, is it?
Yes, your
Better
voice.
now? Uh,
Can you repeat?
okay. Let me just be able to hear me now. Yes. Okay. You're able to hear me,
Yes.
right? Okay. Okay. Okay.
Yes, now.
Yeah. Okay, now you're able to hear me. Okay. So to go back to your question, Faiza, so the registration module within the HCM alone can be taken and can be tweaked to do the census of the population. Now, how do you go about doing it? Right at this point in time, as we speak, we are also building a module. We are also building a tool, admin console, which will enable a person without, coding knowledge to be able to configure it by themselves, right? Add fields, add validations, and do the workflows. So the version 1 has currently been out, and it's in fact getting used for by one of our partners to set up a campaign. So at this point in time, some of the functionalities can be configured using admin console. There is a roadmap to it. So subsequently, it will get addressed. A lot of other features will also come into the admin console to enable countries to do the tweaking by themselves without depending on a developer. But if there are things that are beyond the scope of HCM, which the country wants to do, then there would be a dependence on developer. But again, that is where, like I said, there is an open source platform. We are also parallelly building local capacity across, in India, of course, and also in Africa, which will kind of help the countries to kind of plug in those partners to build whatever is beyond the scope of what HCM and admin console has to offer.
So just adding to Ranjani's point, so Ranjani in the beginning showed that, eGov works in three ways or the three pillars of one is we offer this open source platform, which is Digit, Second is we enhance or build capacity of the local, stakeholders. So if it's a program partner, policy partner, SI partner, we help and we hold and provide complete enablement workshop for them so that they can customize it, whatever product currently as exist for their own contextual needs. So we provide that support as well from eGov. And the third is we work very closely with multiple partners. So we have across 200 partners as of now. So it's more from a like multiple lenses, tech, program, policy, everything coming together for any implementation. Any other? So Faisal, does that answer your questions, or do you have any follow-up questions? Okay, thank you. So what I've also done is I have shared the email ID on the chat box, so you can reach out to us, write to us. We'll get back to you if demo is required, if any material is required. Visit our eGov website, and you can find all the recordings of the previous sessions that we have done and upcoming. So you have access to all the materials that we are using for these sessions. Any other questions that we have? If not, then we'll call it a day. Thank you so much, everyone, for joining. Thank you, Ranjani, for taking us through such wonderful presentation. I hope and we answered all the questions. I hope we answered well. Looking forward for the next sessions. Thank you, everyone. Thank you so much for joining.
Thank you. Thank you very much.